nitrogliserinin yeri yok. Sonuç olarak ben şunu söyleyebilirim. Birçok farmakolojik molekülün aksine zaman geçtikçe modası geçeceğine, değerden düşeceğine, değer kazanan 130 yıldan beri devam eden kullanımımızda olan sarsılmaz bir yeri olan bir molekülden bahsediyoruz. Ve bu molekül sublingual sprey formuyla kolay taşınır, çok çabuk elde edilir. Yanınızda taşıyabileceğiniz, o anda yanınızda olabilen bir form halinde çok özel bir kullanım alanı sunar size diyorum. Ve çok teşekkür ediyorum.
Evet, çok teşekkür ederiz güzel sunum için. Tabii konu hepimizi ilgilendiren çok önemli bir konu. Çünkü hepimiz kullanıyoruz nitratları. Hatta bir ara son slaytlardan nitrat hipertansif ensefalopatide de kullanmaya başlandı tekrar diye kafam karıştı. Sonra yaptık, yani hızla değişiyor, bir kullanıyoruz bir kullanmıyoruz. Ama özellikle sprey formu bu konu daha gündemimize geldi. Biz de bunu anlatalım istedik. Burada şimdi yönetici pozisyonda hocalarımız var, dekanlarımız burada. Hem Mehmet hocamız hem de Ayhan hoca da geldi, sağ olsunlar. Şimdi biz bunların acil servislerde kullanımını destekliyoruz. Mehmet hocam, ben bu konuda aslında 112'nin işte genel müdürlükle görüşüp ambulanslarda olmasını, çünkü prehospital alanda da dediniz değil mi? Olmasının uygun olduğunu düşündüğümü ifade ettim. Ne dersiniz, ambulanslarda kullanılsın mı bu açık. Hastane öncesi?
Tabii ki, yani Türk filmi sahnelerinde kullanıldığına göre bundan yıllar önce çok
ben prehospital'la ilgili makalelere özellikle de koydum Mehmet abi, bu konudan bahis açarız diye. Ambulanslarda kullanımıyla özellikle acil servislerde zaten bulunması
Zeynep
lazım.
hocam, şöyle bir şey de var ama acil önce deneyimleyecek, öne çıkartacak. Yani bizde işler öyle yürür. Yani bizim önce acil serviste bir defa nitratlara ihtiyacımız var. O yüzden sayın dekanlarımıza iletiyorum. Bir defa acile alalım. Acilde olduktan sonra bu kullanım deneyimini biz mutlaka ambulanslara yansıtmamız lazım. Yani ambulanslar acilden aldığı bilgilerle hareket edebilir. O yüzden direkt onlara şunu kullanın demeden önce bizim acilde önce bir şeyimiz olsun da, kullanım alanımız olsun. Ondan sonra oluşturalım diye istiyoruz ama her halükarda sprey kullanımının avantajlı olduğunu görüyoruz. Nitratların kullanımının herkesin bir deneyimi var. IV nitrogliserin kullanmayan yoktur aramızda, acilci olduğumuz için. Bir de böyle alternatif formların çıkması çok iyi. Soru, katkı alabiliriz salondan. Pek soru katkı yoksa biz soralım falan diyormuşum. O zaman çekilişi getirin bari. Çekiliş yok mu? Kimse sormuyor. Çekiliş yapalım. Nitratlar tanıdık. Onu da söyledim. Bak, bu soruya ödül ver. Trinitrin de hatırladın mı Mehmet hocam? O sarı kutu. Bir de o şey vardı. Yaşlı amca alıyordu, böyle göğsüne alıp iyileşiyordu hemen. Şimdi arkadaşlar, ben bunu karıştırıyorum. Ondan sonra bir tane isim çekeceğim. Emine Aykol. Emine Aykol burada mı? Yok, şansını kaybetti maalesef, üzgünüm. Bence ikinci şans. Emine Aykol yok. Ona da söyleyeyim, biraz içi yansın. Derste olmadı. Şimdi şunu çekiyoruz. Bir dakika, şu geldi. Bunu okuma şansım yok ya. Şimdi soyadı Değer ama. Soyadı Değer.
Rabia Değer olabilir mi?
Rabia mı? Vay, Rabia Değer. Evet, alkışlarımızla. Tamam Rabia, ne istiyorsun? Sen böyle bir kura gördün mü? Bak, ne istiyorsun? Ona bırakalım.
Vay, çok güzel.
Yani hocam, haddimi aşmazsam, az evvel Menderes abiyle standın başında konuşurken ATLS kılavuzunu gördüm, biz satmıyoruz dedi. Satar mı, ne yapar bilmiyorum. Efendim?
Çok da mütevazi bir isteği var. ATLS
Yani ilk aklıma gelen oydu diye.
Tamam, ATLS kılavuzu içeren bir kitap istiyorsunuz. Tamam, anladık. Ama çok mütevazisiniz. Ben de daha doğrusu bunlar
Kursunu
öyle mi?
isteyebilirim ama yani
Yok,
ilk aklıma o
yok,
geldi.
bir şey soracağım. Rabia, öncelikle cevap şöyle, hocam canınızın sağlığını isteriz diye bir cevap oluyor. Bunları öğretelim asistanlarımıza. Önce can sağlığı. Evet. Şimdi Rabia Hanım'a o zaman ATLS kılavuzu içeren bir kitap istediniz. Tamam, bunu temin edeceğiz.
Bence kongre falan istiyor.
Ben kitabını kendi adresine gönderebilirim.
Tamam. Behçet Hoca sponsor oldu kitap. Behçet Hoca mı gelmiş? O Behçet Hoca mı?
Odur, evet.
Galiba
Tamam, hoş geldin hocam. Behçet Hoca size kitap gönderecekmiş. Tamam. O zaman siz başka bir şey isteyin.
Behçet Hocam ATLS kursu hediye etsin Rabia'ya.
Tamam.
Behçet
Neyse,
Hocam
yok,
ATLS
başka bir şey yok artık. Başka bir şey yok. Evet.
Teşekkür ederim hocam, sağ olun.
Behçet Hocam, siz baklava yollasanız daha iyi olmaz mıydı? Neyse. Evet. Behçet Hoca da geldi, renklenecek şey tabii. Kongremiz biraz daha renklenecek. Evet, Mehmet Hocam buyurun. Sayın Dekanım buyurun.
Şimdi bir devlet büyüğümüz bir seçim sonrası yüksek oy alması nedeniyle bir şehre geldiğinde dile benden ne dilerseniz diye söylediğinde şehir halkı demiş ki ya sizin sağlığınız Rabia da biraz öyle oldu ama buna cesurca şey yapmak lazım. Behçet Hoca herhalde bunu tamamlayacak.
Evet. Tamam, ben de huzurunuza ATLS kursunu arkadaşımıza hediye ediyorum. Tamam.
Teşekkür ederim hocam, sağ olun.
Behçet Hocam, yanlış anlamadıysam siz hediye ediyorsunuz. Bizi karıştırmıyorsunuz değil mi? Tamam. Evet. Tamam.
Tamam.
Peki. Behçet Hoca hediye ediyor, tamam. Ona göre. Tamam, peki. Teşekkürler arkadaşlar. Şimdi arkadaşlar, bugün performansınız için teşekkür ediyorum. Burada olduğunuz için teşekkür ediyorum. Daha fazla vaktinizi almayalım. Diğer şeye geçelim. Ama bakın, bugün Avustralya'dan gelen bir konuğumuz var. Kaç saatte geliniyor? En uzak uçuş herhalde Yeni Zelanda ve Avustralya. Yani lütfen arkadaşlarımız, özellikle buradaki arkadaşlar öyle hani bu ne demek istediğimi hemen anlıyorsunuz. Bu misafirlerimize bilimsel saygımızı gösterelim. Ve burada onları dinlemeye çalışalım. Gerçekten elimizden geldiğini biliyorum. Bu çalışkan bir ekip var. Her tarafa koşturuyorsunuz. Bildiriler, A salonu, B salonu. Bir de diğer ekip var. Ona da bir o havuza, bir diğer havuza, bir şunun da tadına bakalım. Bir de şuraya bakalım. Ama ne yapalım? Biz böyleyiz işte. Onlar öyle, biz böyle. Bu taraf onun. Biz eninde sonunda kazanan çalışan olur diye düşünüyoruz. Onlar da yadırgamıyoruz. Yani ne yapsınlar? Onlar da bir şekilde şey yapıyor ama artık buraya da önem verelim. Hemen yani B salonunda, C salonunda gitmek zorunda olanlar gitsin. Sayın Hocam, başka bir soru gelmiyor anladığım kadarıyla. O zaman sizi de yormayalım. Teşekkür ediyoruz. Farmetik firmasına teşekkürlerimizi iletiyoruz. Ayrıca bu ürünü Türkiye'ye kazandırmanız da bizim için büyük mutluluk verici. Siz bakmayın, biz bunun peşini bırakmayız. Biz onu ambulanslara falan isteriz. Su sağlık için önemli yani, sizden bağımsız olarak. Biz bunun tecrübesini biliyoruz. İnsanlarımız için bunu isteyeceğiz, merak etmeyin sonuna kadar. Tabii burada bir sürü öğrencimizi de yerleştirdik oraya, biliyorsunuz. Onlar da yardımcı olacaktır bakanlıkta. Evet arkadaşlar, 4'te diğer sunuma geçiyoruz ve bugünkü son iki sunumumuz. Burada da yabancılar, kalabilen arkadaşların burada kalmasını istiyoruz. Hatta burada kalanlara sürekli şey yapalım, sürekli çekiliş yapalım. Madem birini de Behçet Hoca verdi, burada kalanlara bir çekiliş daha yapacağız. Ama kaldıktan sonra. Teşekkür.
Department and Poison Center for taking any kind of an help. So with this, I thank you all very much for giving me an opportunity, and I welcome you all to MCON 2022, which will be happening from November 24th to 27th in India, in Trivandrum. It's a God's own country, it's called as. So welcome you all. Thank you very much.
Thank you, Doctor, for interesting lecture. Thank you.
Thank you.
Next speaker will be by Dr. Ahmed Dhoum. Dr. Ahmed is a Lieutenant Colonel in the Royal Medical Services, emergency consultant European and France Emergency Fellowship Louis Pasteur University, ICU and Critical Care Training, Basket University, Director of NIMSIC. He will speak about the role of the NIMSIC Training Center at Royal Medical Services to improve the quality of the emergency medicine. From Jordan. Thank you, Doctor.
Good afternoon. It gives me a great pleasure to be among you. Thank you, IBAD colleagues, for invitation. And thank you, Professor Bashar, also, and the organizing committee. It's give me honor and great to introduce my organization, Jordanian Royal Medical Services, in a few slides. As you see, we have around 24,000 Royal Medical Service personnel, 11 or 12 institute and military hospitals, 4 military hospitals. Our Royal Medical Service mission, it's multi-focus organization working under the mission of providing, improving and developing efficient by using optimal using of available resources. As I informed, the RMS Jordanian rules, military rule, national rule, international humanitarian rule, crisis and disaster management. Our Royal Medical Service structure, we have around 12 hospitals from north to south, east to west, 6 field hospital, 4 military battalion hospital. This is our King Hussein Medical City, the largest and most disciplinary medical institution in Jordan. It contains around 6 special hospitals and preventive medicine, also nuclear medicine and ophthalmology center. The capacity of beds around 1,400 beds. Also, we have 4 military academy, Prince Muna Royal Medical Service College and Institute Biomedical, and my National Emergency Medical Service Training Center. With pleasure to share with you our experience. I am the director of the National Emergency Medical Service Educational Center at the Royal Medical Services, and how we have the courses to increase the efficiency for emergency physicians. Our vision, excellence and leadership nationally, regionally and globally. Our mission to provide state-of-art training program that keep evidence-based guidelines through optimal use of available resources, including well-qualified instructors, modern technology, and appropriate setting. In 2009, our training center, NIMSIC, was accredited by American Heart Association, and we started to conduct basic life support, advanced cardiac life support, pediatric advanced life support, pediatric emergency recognition and stabilization, in addition of neonatal resuscitation program, and also triage courses. Also, it is these courses for physicians, nurses, midwives, paramedics, and also for non-healthcare providers. In 2013, our center accredited by American Cardiac of Surgery, and we conduct advanced trauma life support for physicians, for doctors. In 2015 also, we are accredited by American Society of Trauma Nurses in cooperation with American College of Surgeons to conduct advanced trauma care for nurses also. In 2015 also, accredited by American National Association of Emergency Medical Technician, NAMET, and we provide PHTLS, pre-hospital trauma life support for doctors, nurses, and paramedics. In 2019, we accredited by American Academy of Family Physicians, and we started to conduct basic life support in obstetric and advanced life support in obstetric. Our training center, at NIMSIC, has ability to conduct different type of courses to cover all target group in the community. It's not also for doctors, for nurses, for midwives, across designed also for non-healthcare providers. As the models of emergency medicine, we know there is two models of emergency medicines: stay and play philosophy or scoop and run. So that in our center, we started to have both of them, to have a courses pre-hospital and also in hospital. It is our accreditation from training center. This slide, it gives us information how many participants in our training center. It is not only for emergency physician, but also GPs. And what we are did that the all medical or Royal Medical Service doctors, they didn't have promotion from rank to rank, or from, for example, specialist to senior specialist or consultant, if he didn't pass some of these courses. As you see, basic life support around 150 per 1 year. We have advanced cardiac life support, PULSE, peers for pediatrics, NRP also for program of neonatal, emergency triage, PULSE, and also basic life support, advanced life support for doctors. They are working in as pediatrician or gynecologist, advanced trauma life support for doctors. They are working with a trauma or surgeon, pre-hospital trauma life support also for all paramedics and doctors. They are working in the field. Also, we have TCCC, Tactical Compound Casualty Care, Tactical Emergency Casualty Care, and also Tactical Medic, Emergency Medical Technician Basic and Intermediate. To rising the paramedics, we have for newcomer and Emergency Medical Technician qualification. As I mentioned before, our American Heart Association courses, it's basic life support. I think you are familiar with these courses: advanced cardiac life support, pediatric advanced life support, pediatric emergency assessment and recognition. Also trauma courses, advanced trauma life support, ATLS, and we congratulations Professor Bahjat that you are instructor of ATLS, I think, in Turkey. ATCN also for nurses, as I mentioned before, pre-hospital trauma life support, and all of these courses, it's very important to rising the efficiency for emergency physicians. They are working at emergency or at the field. The importance of courses that conducted at our training center, that they provide conscious of easy to remember framework for the medical personnel who involved in the courses. When they come across with any medical emergency, they will be able for optimal using of available resources and teamwork dynamics. Others courses we have like Diploma of Emergency, Neonatal Triage also, and tactical courses for non-medical health provider. This is the average of our courses during the year. We cover around 90% from our military Royal Medical Service, and the statistics 10% from the civilian people. Thank you very much.
Thank you, Dr. Ahmad. The last speaker at this session, he will be Professor Dr. Rajadoura. He is Senior Consultant and Head Department of Emergency Medicine and Critical Care at Apollo KH Hospitals in Milfishar from India. And he will talk about evolution of pre-hospital care in India and the way forward.
Okay, we can do it. Thank you for that nice little introduction. Thank you for the opportunity. So I'm going to talk about the journey of pre-hospital care in India since a decade. And the good news is I'm going to talk within 10 minutes. And I'm going to keep my lecture short as possible. Well, not this short. So who said the thank you slide have to be only in the end? So I take this time to thank the organizers for giving us the kind of opportunity. Professor, the President, EPAT, and all his team, our SEMI team, and all the organizers for giving us this wonderful opportunity to speak on the platform, which deserves this kind of topic. Is this topic important? So most of my presentation will have this slide as a mandate, where I'll usually engage the participants about whether the pre-hospital or the topic what I'm going to talk is important. So here, the pre-hospital core, probably after some slides you'll understand whether the pre-hospital care is important or not. So these are all some of the statistics across the world, where we see 80% of the deaths occur outside the hospital. So please note that it is not the deaths which is happening only inside the hospital. In a developed nation or a developing nation or in the Western countries, we come across more deaths outside the hospital. And this is a statistics which was taken 5 years before the COVID. So it is still rising. Over 2 lakh people die of sudden cardiac arrest every year. And the single most strategy to improve the victim's chance of survival is always bystander CPR, and the single most effective intervention that has saved maximum lives in the history is CPR, which is bystander CPR. So let's talk why we need early CPR. I am sure this is a crowd where you all know aware of about the platinum 10 minutes and the golden 1 hour concepts, so I'm not going to talk much on this. To be more precise, CPR increases the sustainability of rhythm and the chance of survival, which is the platinum 10 minutes. So this is a familiar slide to all the emergency physicians across who are sitting here, the trimodal death distribution. So do not take only, this pattern is only for trauma. This is for all medical as well as surgical emergencies, including trauma patient who comes to our emergency department. The first, you can see the 3 peaks here, the first phase within minutes, second phase within hours, and the third peak within the days or months. So the first peak usually, they say it is not unable to prevent. So when we have a good pre-hospital care, the chances of that peak is coming down is very highly. That is what we have demonstrated in our country. And the second phase, when we have a good ER, good functioning ER with all, good emergency physicians, trained emergency physicians to train to take care of ACLS, the cardiac life support and trauma life support and all emergencies, this peak also can come down. When the accessibility and the emergency physicians, the ambulance services, which all I'm going to talk in the next coming slides, we can bring down these peaks also. And the third peak, which happens mostly inside the hospital, either in the ICU or in the wards. So death due to infection or multi-organ failure, when you have a good team of doctors working along with you, and when you have good pre-hospital care and the emergency care, the chance of you reducing the third peak of death is also inevitable. Right, so this is a trauma statistics. This is our country, India. Most of you all know. So by the time I was talking, I was talking for the past 2 minutes, a death would have happened by now. Death related to trauma and other medical emergencies would have happened. So every 2 minutes a death is happening because of trauma or related to it. And these are the various state-wise representation of deaths which is happening inside our country. So how do we prevent or how do we reduce the chances? So we need to improve the pre-hospital care. As I said, the first peak have to come down because of the good pre-hospital care. The second peak, we need to improve the knowledge of our emergency physician, improve the basic structure, and improve their skills with regards to treating those critically ill patients, and you need to form a good team in our critical care units and the wards to reduce the third peak. Whether we have done it is not a one-day process, it is a gradual process. And so as it has been mentioned in AHA's chain of survival, you need to follow this interlinked chain of survival without any break. Any break in this interlinked chains reduces the chance of survival for patients. So now you guys tell me, based on the statistics, is this topic important? The pre-hospital care, what we are doing for the past 10 years? Definitely yes. So I'm going to talk a little bit about the journey of our pre-hospital care for the past 10 years in our country. And I'm not going to include, I'm unable to include all the people's work here. So we have included maximum what we could do for this objective. In short, the short objective would be to save lives. So a typical scenario on Indian roads, a road traffic accident. So what do you think people would be doing there? Or what do you think a healthcare professional would be doing there? A good Samaritan, ADMAX, even now, would try to ask for an ambulance, to try to call for an ambulance. Why they are not coming forward to help these victims? Of course, there are places where people are helping and people are doing resuscitation. People are trying to help each other, but not everywhere it is happening, particularly not only in our country, almost all the countries. Why? When we assess the reasons, we found that it is lack of awareness, because people are scared when somebody is fallen, collapsed, and with a lot of blood, and somebody screaming or screaming next to the patient. Somebody has fallen unconscious because of various reasons. They do not know what they exactly need to do. So it is lack of awareness, fear about the loss. People think that most of the time the bystanders are also harassed after the incident, and they fear about the loss. We don't have a good communication system. The transport ambulances are all short, because I'm from a country where about 1.4 billion people are there in that single country, as Dr. Srinath was telling. So we and China together can match the rest of the population throughout the world. So accessing to the ambulances, communication system, access to the healthcare, and a trained emergency physician are all pitfalls. So what, as a group, as Society for Emergency Medicine, as each and every emergency physician in India have done so far. So what we thought is, we have to give widespread CPR training, develop rapid responses, establish high quality CPR and training to them, where like fire extinguishers in Western countries, we also need AEDs throughout our country, and we need to have a good definitive care. So this is some huge task, and as I told you, we didn't establish this in an overnight, and this is a decade of efforts which I'm going to show you all. Of course, nothing happens unless we dream. We dreamt of the same, and to some extent we have, arrived to this. A dream of every emergency physician, at least one BLS provider in each and every home. This was a dream since a long time, and we need to create mass awareness, that is large volume, high frequency, large volume, low frequency, and as well as low volume, high frequency training is what we aimed at, to create awareness to the general public as well as to the other people. So this is, ladies and gentlemen, this is a red letter day for throughout all the emergency physicians in India. On April 7, 2016, we trained about 50,000 people. Can you all imagine? We trained about 50,000 people in CPR, and it has been in the Guinness World Book of Records. We as a society have participated, and we have done it in the institution where I was working. So by this, we created a mass awareness. Each and every emergency physician society, after this, we thought, when I was having a meeting with the media, one of the media person asked me, when do you think this record will be broken? I told to them, I wanted this record to be broken the next day. Even the organizers was slightly not happy with me, having spent crores when I was telling that I want this record to be broken, because we didn't do record for records, we do this record for awareness. So more and more such records, where it comes, more and more people will be aware, and as expected, like a chain reaction, a lot of people attempted. And of course, ladies and gentlemen, this record still remains unbeaten, and many of the people have done subsequent records in CPR in different categories. So this is one such scene from that. this is me. I think we need to, Dr. Srinath will agree, we need to perform Guinness World Record to keep ourselves slim, isn't it? So this was me training about 5,000 people at one go. So we had about 8 sessions where we trained about 40,000 people, and subsequently there was a relay about 10,000 people. So on that particular day, that is on 2016 April 7th, we trained about 50,000 people, and this was marked in the Guinness World Book of Records. But creating a record, as I told, it is not good. It is a one-time event. It is not going to help much. We need to focus on the low volume, high frequency training, which we are aware, and we identified the end users, the school, college students, police, fire, and district officials, and we started training for them too, which has been happening for the past, from the time we established as a society in emergency medicine. Each and every physician is doing their part to do the same, and we are also doing the same. So this is the present hospital where I was working. Of course, every hospital, every emergency physician are donating AEDs to make AEDs available in different parts of India, and we are training people to the first aid thing. And this is the integration of first aid and school curriculum. Most of the emergency physicians across the world go to the school, train them in CPR, and then come back. Instead, what we have made in our group is, what we have made in our place is, we have integrated first aid in the school curriculum, like how the kids will learn maths or physics, they will learn CPR. CPR is a non-exam subject. So it is a compulsorily, it has been taught in each and every, the school student of that particular school, and he will be trained in CPR. That is our goal. So once he's trained, he's been certified, we have a process, and he's been certified, he's been retrained. So we see to that the integration of first aid in school curriculum happens even now in the right way. Of course, as I was telling you, the small volume, concentrating on the small volume, we as a SEMI was doing this national level basic life support and cardiac life support. It is a replica of AHA's, American Heart Association's basic life support. For the people who are unable to participate there, we have formed this. It is an interactive session where we train a lot of people on every day in different cities. So this is the National Trauma Life Support. So this platform is a peculiar or an interesting opportunity, I would call, because I'm sharing all these things in front of our academic chair, Dr. Srinath. So this is the training report what we have from the last year. This training is provided to all the government doctors, and this is done as a pilot course in Tamil Nadu, a state in India, which has pioneered this aspect of spreading training to the doctors, combining with the government. This shortly will be adapted to all the states. We are spearheading for the same, and more people will be trained for the same. So these two, Dr. Srinath and Dr. Sarana Kumar, are the program directors who developed the group of people and organized the team to teach each and every medical colleges. So we are doing this for the past 2 years. We have trained about 15 medical colleges in across Tamil Nadu. As it is again like an advanced trauma life support 3-day course with interactive lectures, hands-on training, Kahoot online quizzes, and pre-test and post-test. On the completion, they will be given a certificate. So we didn't do just the course, we assessed the outcomes also. As the graphs clearly mention, the knowledge post this NTLS course was very high to the participants, and this is what exactly we wanted at the end. So when it comes to the ambulances, of course, the drone ambulance is coming into the picture, which I'll be talking in the newer advances. We have road ambulances. Of course, we have pioneered the air ambulances across India, and we have separate teams to take care of air services as on date. And we have what is called as bike ambulances, which we introduced a decade before in our country, to assess the narrow roads to help the victim as soon as possible. So of course, we cannot be expecting everyone to be a good Samaritan. So we have, approached the government to look after few guidelines to help the victims. So in that way, we have suggested that, every the bystander have to help if there is a patient suffering from the unconsciousness or after a polytrauma. So he has to be trained, and the legal system should not harm the Good Samaritan in any way, is what we have suggested to the legal system, and it has been carried out in a right way. Hopefully we have a system where people will be helping out and will be scared if they don't help out. Of course, I was talking about the innovations. We have drones. We have developed drones to help people. This is in the pilot project, and hopefully we'll have drones all across in the country in a short while. Of course, the telemedicine, Dr. Srinath was mentioning about the telemedicine, which has played a vital role during our COVID scenarios. And we have developed several applications for the patients to approach the hospital, the ambulances, in a way it is very effective. Right. So this is the slide which I am projecting again. So for your country to develop the pre-hospital care, you cannot do that on day one or within a short span of time. You need to have a specific period of time for which, and of course it is an ongoing, so you need to have widespread CPR training, both large volumes as well as small volumes. We need to develop rapid response and AEDs and definitive care. So there is no I in teamwork, right? Everyone can be a superhero if they combine together when it comes to emergency medicine. Once again, thank you for the opportunity given to me.
Thanks for all speakers at this session, and it was interesting lectures, and they have enough time to listen to your comments or if you have any questions to them.
Thank you very much. This is Dr. Behçet from Istanbul. Each speech was really very nice. Great. Thank you to everybody, to all speakers. Just my first question to Dr. Srinath. Can we hope for new antidotes in toxicology? This is for you, infection especially. And for the Dr. Ahmed, is it necessary to have all these trainings in Jordan? Is it must? I just want to learn it. Then for the last one for Raja, thank you very much for your sharings. Just firstly, I want to appreciate and say congratulations to the Savitri University in India for their basic life support and first care that they teach to the community. But the photo should be specific to India. It must be really very difficult to teach basic life support or first care to 1,000 people in stadiums. But it is specific to India. As you said, as you mentioned, over 18% of the deaths happen in outsourced hospitals. So I'm really agreeing with you. Your question is really very important, definitely, very important. As you mentioned about the dreams, I think all the reality should be given from the dreams. You know, there is a philosopher in your country, one of your previous presidents, he says, the dream is not the thing that you saw while in your sleep. The dream is thing that doesn't make you to sleep. So that's why I want to appreciate you. You are teaching the community about the first care, first aid in India. This is one of my dreams. I just have a suggestion. Can we achieve it? To teach all the students graduate from the university, and it could be must to teach the basic life support or first care to all the couple that are going to marriage. Thank you very much.
Second question.
Yeah. So the first question is towards the antidotes. Yes, there are a lot of things which is happening, and especially if you visit to many emergency departments now, they have created the disease-specific antidotes in those emergency departments where they see commonly. If you take me, I have created a full box of antidotes which comes commonly. I have taken an epidemiology of my system where last 2 to 3 years which have come to my emergency department, I have seen that this is what is required. Now the next question is about the newer antidotes, like lots and lots of patients are coming with the the chemical poisoning, especially those requiring the methylene blue. So methylene blue is not available readily in every emergency department. So nitrates have become a biggest poisoning in most of the countries today in Asia. So there we have started using the methylene blue, and it has shown much results, and the patient outcome is also good. And regarding the training, what Dr. Rajdari was mentioning, it was a mission which he took it for almost 6 to 7 years. And then he ensured that all the people come together and it was been done, so that it gave an impact of emergency medicine in the whole country. That is all. Thank you.
Thank you. Thank you, Professor Bahjat, for your nice question. Really, we are share a knowledge. Our technical training department.
We as a society, there's too many, we call them merit badges. It's everyone's another badge. And so philosophically, we believe that all of that training is already incorporated into our residency, so we do not necessarily require each one of these badges, so to speak. So I hope that answered your question, but yes, it's important that we're all doing the same thing. You know, we incorporate ATLS into our training programs. We obviously do ACLS. We do periodic updates for all of our doctors, not just our doctors in training, but our doctors beyond training. And so once they get certified in emergency medicine, you know, every 7 to 10 years, they have to recertify. This used to be a big problem for us in the US, but now what we do is we do a little bit each year. And we find that to be a better situation than having to retake a test every 7 to 10 years.
Thank you for all. No any more question? Thank you for all. Our session is finished. 5 minutes later, we'll start the last session of today. Okay? Thank you.
It's quite an exciting session. My name is Athar Ali Mohammed. I'm one of the ED physicians from Australia, and I have got Dr. Ahmed Al-Joom with me. So there's a slight change in the program. I think the first session we will be kind of starting with the pediatric ocular trauma by Dr. Hesham Kaftan. Thank you, Dr. Kaftan. So Dr. Kaftan works in the emergency trauma team at the King Hussein Medical Services in Jordan, and he works in the head and neck emergency trauma division.
Next page.
Good evening. I'm glad I'm here with you. Our lecture is about the pediatric ocular trauma and emergency. Pediatric ocular trauma is the preventable causes of the visual impairment in the world. Up to 40% of the all injury occur in the person less than 17, especially in the small age. Why it is important? Because as we know, trauma to the eye in the first 6 years is critical, because it leads to lazy eye, amblyopia, as we know. So eye injury are leading causes to the visual disability and non-congenital unilateral blindness in children. Very commonly, eye injury occurring during the sport and even when at the home or school, anywhere. Speak fast about the anatomy of the eye. You know, our eyelid, lower eyelid, cornea, sclera, and the retina and cornea and iris, everything. The most important thing we know about the orbital wall is the lamina papyracea. Lamina papyracea, which is the thinnest bone in the orbital wall. Approach to the eye examination. The history. The details of the mechanism and time of the injury. Where, when, how, and with what. Chemical or alkaline. Change. First, we ask about the change in the vision, flashes, floaters, or any shadow. Symptom: pain, visual loss, double vision, photophobia, or any other symptom. The eye examination. The vital sign, as we know, is the visual acuity, external eye anatomy. Look for trauma, foreign body, or any other. Pupillary response, equal rounded, reactive, full, visual field, extraocular movement. If there's any limitation, we must keep in mind, because there is trauma may the fracture to the orbital wall, so the entrapment for the muscle. Fundoscopic examination is the last and the important thing. If there is chemical bone, proceed for provide copious irrigation before history and before examination, before anything. Imaging study, plain X-ray to look for orbital wall fracture, CT scan to look intraocular foreign body, MRI. If there is metallic foreign body, MRI is contraindicated. Keep in mind. Emergent eye situation, eye trauma, blunt versus sharp, chemical, infectious. First, eye trauma, eye laceration, maybe superficial or deep, special care to the involving the lid margin and the tarsal plate and levator muscle, and the lead maybe lead to the ptosis and that canaliculum, the medial canthus. The latter need tubing technique to prevent it before after healing. Check for associated foreign body or globe injury. Treatment: primary closure or delay closure after 12 to 24 hours if a human bite or contaminated wound. Tetanus prophylaxis for all any skin injury. Full thickness, this is picture like this presented to our emergency. Okay, maybe trauma lead to the subconjunctival hemorrhage. As we know, this is treated with a cold compressor and artificial tears of the symptomatic, and avoid aspirin or NSAIDs and heavy lifting. And this take to 1 or 2 weeks or maybe more to resolve. And maybe trauma lead to corneal or conjunctival foreign body, which is the patients complain of the pain, tearing, photophobia, blepharospasm, and foreign body sensation. We must avert the upper eyelid to look for any hidden foreign body or any entrapment. Treatment: topical anesthesia and remove with the foreign body by the needle or cotton, triangular swab, or topical antibiotic drop or ointment. We must avoid patching in children because it leads to the lazy eye. Like this foreign body, maybe in the upper eyelid, on the inner surface of the upper eyelid or the cornea directly. Corneal abrasion ulcer. It's an epithelial defect due to the trauma occurring by the pain. Foreign body sensation, tearing, blepharospasm, and decreased vision. Dramatic response with installation topical anesthesia because it's pain relief. The ulcer could be sterile or contaminated or infected. If you have the upper eyelid, always as foreign body maybe it is the causes of the ulcer. Treatment: lubricant and topical antibiotic and cycloplegic to relieve the pain. Like this ulcer. Orbital anatomy, as we say previous, the most important is lamina papyracea, which is the thinnest point in the orbital bone. Orbital wall anatomy, orbital wall fracture. Orbital floor fracture, maybe blowout fracture. The most common, as the floor is the weakest part, the roof of the maxillary sinus, usually due to blunt trauma. Symptom and sign: eyelid swelling, diplopia, restricted eye movement, especially upward, due to entrapment of the muscle. Enophthalmos, hyperesthesia over the cheek. Imaging study: plain X-ray or CT, observation with the tetanus prophylaxis, prophylactic antibiotic with a broad spectrum, and nasal decongestion by 2 for 2 weeks. No nose blowing because this is increase the air under and delay the healing. Ice pack 1 to 2 days. Go for surgery if entrapment muscle, oculocardiac reflex, heart rate decrease with eye movement. Facial hyperesthesia, sympathetic diplopia with minimal improvement over the time or large floor fracture, leading to the enophthalmos. Surgery is the most commonly performed if indicated after 1 to 2 weeks if indicated. Like this, there is restriction as we see in the picture because the entrapment of the muscle inferior rectus. Define hyphemia. Hyphemia is the blood in the AC. The anterior chamber usually results due to blunt trauma, projectile, or penetrating trauma, but can be spontaneously, as in juvenile xanthogranuloma. Commonly, in the pediatric population, signs, symptom, pain, decreased vision, and irregular pupil. Clinical grading from 1 to 4 according to the level of the blood in the AC. Complications: secondary hemorrhage, rebleeding, high risk in the first 5 days, and high rate in young children, and cerebrohypemia. Corneal blood vessel stain, anterior, posterior synechiae, optic atrophy. Prognosis outcome: the lower the grade of the hyphemia, the better the prognosis. Management of the hyphemia: complete bed rest, risk of hospitalization or outpatient. Most important is bed rest. Risk of the bleeding, grading of the hyphemia, according to all this control, treat the patient as hospitalization or as outpatient. Elevate the head 30 to 45 degree, eye shield to prevent the rubbing of the eye, pain control, avoid antiplatelet effect, certain NSAIDs. Topical psychologic: atropine, atropamide to reduce the ciliary muscle spasm and dilated of the iris to decrease the rebleeding risk. Topical maybe need drugs to decrease IOP, and topical or systemic steroid to decrease associated iritis and development of the synechiae. As this picture of the hyphemia, blood in the AC. Okay, retrobulbar hemorrhage. As we know, retrobulbar from the most important and cases presented to the emergency can result in the rapid elevation of the orbital pressure because of the orbit is a relatively closed compartment. Untreated orbital compartment syndrome may result in the optic nerve ischemia and irreversible vision loss and less than 90 minutes. This is maybe spontaneous or traumatic. Signs, symptom, pain, decreased vision, diplopia, globoptosis, and lidichemosis and tightness, and subconjunctival hemorrhage all over 36 degree, with chemosis and limited muscle motility and increased IOP. Decreased visual acuity and people response, positive rapid treatment, lateral cathetomy and catholysis, or maybe can you give hypertonic saline 20%, 20 milli slowly over 20 minutes. Like this, retrobulbar hemorrhage. Okay, iridodialysis, separation of the iris may be result from the trauma to the iris, blunt trauma. Separation of the iris from its root due to blunt trauma. Or maybe the result of the trauma is ectopia lentis, subluxated of the lens from its normal position, maybe downward or in the anterior chamber, according to the mechanism of trauma. Optic nerve avulsion, which is very rare to happen. Partial or complete avulsion of the optic nerve as a result of the trauma that lead to the sudden extreme rotation of the globe or sudden anterior displacement of the globe. Retinal detachment is immediately post-traumatic or maybe delay up to several months. Separation of the neurosensory retina from its base. Rupture of the globe may be a result from the trauma. Full thickness laceration of the globe as a result of the trauma that may be within blunt or penetrating or perforating object. Can be corneal scleral or combined corneal scleral. Symptom: pain, greatly decrease in the vision, diplopia. Sign: low IOP, teardrop pupil, prolapsed iris, hyphemia, maybe with normal or high IOP, 360-degree subconjunctival hemorrhage all over. Management: if suspected rupture, minimize manipulation of the globe and apply the protective eye shield. CT orbital or brain axial coronal with thin cut, coronal thin cut to evaluate for the intraocular foreign body. And keep patient NPO in order to prepare for the surgery under GA. IV antibiotic to cover, especially in the children, and antiemetic pain medication, surgical repair is the definite treatment. This is rupture of the eye, like this picture presented to our hospital. Okay. The most important, again, ocular chemical burn. Being irrigation immediately before complete history and examination. We must directly start it by irrigation, especially if alkaline, because alkaline is more detergent than acidic. Alkaline burn are worse than acidic burn. Acidic burn lead to coagulative necrosis, denaturation of the tissue protein, act as a barrier to prevent further diffusion and further penetration for the acid, as battery fluid and chemistry lab solution. Alkaline liquefative necrosis don't denature tissue protein, tend to penetrate deep in the eye, like cement cleaner, drain cleaner, fertilize, any other alkaline burn, because they contain sodium hydroxide. Clinical finding: conjunctival hyperemia, blanching. The latter has bad prognosis and indicate severe ischemia, hemosis, corneal epithelial erosion, and corneal haziness and edema, and severe corneal opacification, limited ischemia all over. Complication: corneal melting, severe corneal and conjunctival scarring, uveitis, glaucoma, and maybe lead to the loss of the vision in this eye. Like this chemical injury, which is very dangerous. Ocular chemical burn, continuous management, immediate irrigation with normal saline or lactic ringer or ringer lactate for at least 30 minutes until the pH is normalized, maybe require up to 8 liters. Do before checking VA or hospital or a history or an examination or fluorescein, and recheck pH 5 minutes later in order to be sure that his pH is normalized. After irrigation, check the visual acuity and complete the examination. Treatment: give any ointment like erythromycin 1 to 2 hours with cycloplegic atropine, and may need IOP lowering or steroid. Eye infection in ophthalmic retinum is conjunctivitis within the first month of the life. Common causes is chlamydia, and this is from the cases presented to the emergency because this small baby and her parent is very fair, like chlamydia, trachomatis, and staphylococcus, strep, Neisseria, gonorrhea, and herpes. Sign: purulent gonococcal and or mucopurulent discharge, conjunctival injected, and eye edema, chemosis. Management: conjunctival scrubbing for gram-positive and stain, chlamydia antibiotic test, culture, blood and chocolate agar, and viral culture for them. Treatment with topical antibiotic, eye drop, and or ointment, and guided by the result of the gram and negative. If chlamydia trachomatis, treat with the systemic erythromycin, and since pneumonitis and otitis media can coexist with the erythromycin ointment 4 times per day. Acute conjunctivitis, the last, maybe viral, chemical, bacterial conjunctivitis, mucopurulent discharge, viral watery discharge, treat as bacterial, topical antibiotic, and expectation is the gonococcal, which is the required systemic antibiotic and topical drop. Viral supportive treatment with cold compressor and artificial tears, which is highly contagious for 1 up to 10 days. So we must be careful with the deal with this patient with the virus because it's highly contagious. Cellulitis. Cellulitis may be preseptal or orbital cellulitis. Common organism: staph aureus, staph epidermidis, or strep pyogenes, and Haemophilus influenza. Preseptal cellulitis involve soft tissue of the eyelid and preorbital tissue anterior to the orbital septum. Patient presented with erythema, swelling, tenderness, eyelid, and surrounding preorbital area. Orbital cellulitis, more serious infection, involve extension of the infection posterior to the orbital septum, which is more danger than preseptal. And the risk, it's danger due to the risk of the cavernous sinus thrombosis, and meaning that's brain abscess. Proptosis and ophthalmoplegia decrease vision, significant pain on the eye movement, and abnormal pupil, and decrease in the vision and the color vision defect. Like this. orbital cellulitis. Picture. Treatment of the cellulitis. Mild preceptal cellulitis, oral antibiotic may be enough. Severe preceptal or orbital cellulitis, you must admit the patient and start on the IV antibiotic with a broad spectrum until the infectious agent is identified. Can add a topical antibiotic ointment. So we must ENT consultate if the sinusitis or mucopurulent, and if the patient is immunocompromised, consider mucormycosis and severe fungal infection with a black Yards sign in the nose or roof of the mouth. Immediate surgical debridement and antifungal treatment. Thank you for attention.
Thank you. Thank you very much, Dr. Hisham, for your presentation. All the questions, it will be after the finishing of the session. We are, as emergency physician, really we are looking to deal with these cases in ophthalmology. With the pleasure to introduce our next speaker, Major Dr. Arij. She is family medicine specialist, training fellowship in community medicine, master degree, working as representative of infectious disease at the Royal Medical Services. She will talk about public health emergencies in our Royal Medical Services. Please, Dr. Arij.
Good evening, everybody. Thank you, Dr. Ahmed, for introducing me at this sweetie way. And also thanks for organizing committee for kindly invitation to me. And I'm really so happy and proud to be here with you today as a guest speaker. Today I'm going to talk about public health emerging disease, and I will give more details or focus on one disease of it, which is seasonal flu. And really I have chosen really flu, this topic, because you know influenza familial, okay. I have chosen this topic because you know, influenza familial for all of us, and is constantly re-emerging disease because it's, as we know, it has genetic variation and rapid adaptation, which allow virus to serve up new strains each cold and flu season. And that occurs because immune system or our bodies not primed to fight. Let's start. First, we must differentiate it between, both of it are epidemiological terms, which is emerging and re-emerging disease. Emerging disease defines as disease that haven't really appeared in a population or have existed, but are rapidly increased in incidence or geographic range. And the most important example, it's a COVID-19 of emerging disease. About re-emerging disease, we can define it as diseases that reappear after they have been on a significant decline, or re-emergence may happen because of breakdown in the public health measures for disease that were once under control. And the most important example for it nowadays, which is cholera. Cholera in most Middle East countries and all over the world, we can see more cases of cholera, but now in the Syria we have epidemics of cholera. And what we mean by epidemics, it's also epidemiological terms, it's occurrence of disease in normal of expectancy. And all the countries around the Syria or had refugees from Syria now prepare new guidelines to control these cases if we have more cases in our country. They can also happen when new strains of unknown disease causing organisms appear. I will give more details about influenza, seasonal flu. It's RNA enveloped virus. It's related to family called Orthomyxoviridie. It's very, very, very small. this picture, it's under microscope. It's about 80 to 200 nanometers. We have more than 400 types of viruses, but we will focus mainly on the 3 types, A, B, and C. And about the B and C, we have not genetic mutation over it. More the mutation we can see with the strain A. So also we will focus on the serotype A. About the A, it have something which is called glycoproteins over the surface of the virus. Glycoprotein antigens, which is called H and N. H refer to hemagglutinin and N refer to the neuroaminidase. These pictures give us more details about how these glycoproteins present on the outer surface of the virus, and if we have any genetic mutations, it will be happen at these glycoproteins. In the influenza, how its mutation or that mutation happen? It through something which is called antigenic shift and drift. What we mean by antigenic drift and shift, at what's the main differences between it? About the antigenic drift, it's a slow change, and the main difference between the antigenic shift and drift, it's a slow change in the viral genes due to replicating error or random mutations result in the new virus strain, and that's what happened with seasonal flu every year. But about shift, it's rapid and large antigenic change in a virus and requires at least, we need 2 different types or serotypes or strains to combine to form a new viral serotypes. Also, we have another name for it, which is called phenotyping change. And the most familiar example of us, what happened in the swine flu, H1N1 and H5N1. Let's give more details about influenza flu. Why it's important? Because we have every year about 9 to 41 million cases. And despite how common is it, it's a serious disease. And every year we have 450,000 deaths and about 650,000 hospitalization occur in all age groups because of it. We have high-risk group. We can see the more number of deaths in this high-risk group. Healthy children can die from the flu. The younger the child is the higher risk for serious flu complication. And this complication we can see in this high-risk group, which is an older age than 60, a younger age than 2 years, and if it's in units, also we can see more complication with it. Also, any immunocompromised patient due any cause, they are on the chemo, on the chemoprophylaxis drugs. Also patients with a chronic disease such as hypertension and DM for long period. They will suffer more if we have influenza flu, seasonal flu. So when we give vaccine and talk about the flu vaccine, we will focus on this high-risk group. Young children are at high risk for serious flu complications such as secondary bacterial pneumonia, ear and sinus infections, and also dehydration. Now let's give you some information about seasonal flu. As we know, seasonal flu incubation period about an average from 5 to 7 days and average about 4 days. We have symptoms appear about 2 days before. The patient will be infectious to others about 2 days before appearance of sign and symptoms. And about sign and symptoms, all of us are familiar with it, which is general weakness, headache, low back pain, also low-grade fevers, and بالإضافة اللي هي عندنا اللي هي respiratory symptoms such as the productive cough. About the treatment of it, as we know, antibiotic is not effective for treat because it's viral, so we use antiviral. And the most important prophylaxis measures, which is اللي راح talk about اللي هو الvaccine, الflu seasonal flu vaccine. Mainly we have 3 types of the vaccine. Contains اللي هي عندنا أول شيء the first weakened pathogens اللي هي life attenuated, which we called life attenuated vaccine, and inactivated, or which we called inactivated vaccine or killed vaccine. It's the same pathogen. It can't make us sick. And also we have, if we have made the vaccine from subunits of the virus, which is a smaller part of pathogen like an antigens. What's the main differences between 3 types? A life attenuated vaccine, it give us something which is called lifelong immunity. So in the future we don't need extra or booster doses of the vaccine. But about inactivated, we still need more doses and booster doses of the vaccine because it doesn't give us lifelong immunity. And about اللي هي subunit like طبعا اللي هو الانجريكس or hepatitis B vaccine, the most example of it. Life attenuated, the most example of it, which is the mumps, measles and rubella vaccine. And the inactivated اللي هو seasonal flu vaccine, example of it. All vaccine mechanism of actions contains antigens which trigger the immune system to create specific antibodies, which is we called memory antibodies, and it will give a signal for pathogen destruction in the future. What's the benefits of the vaccines? It provides us protection from pathogens which can kill or make you sick. Also, we use this to control and eradication of once common pathogens like polio, smallpox. Polio, it's one of the re-emerging disease. It stops outbreaks and global epidemics, and that's what will happen with the COVID-19. The COVID vaccine, it have a great role to stop outbreaks and the global epidemics. About the risks and challenges, we must know about the vaccine. We must know no medicine is 100% effective. So people can sometimes still catch the pathogen, but this is very, very, very rare. Side effects, maybe we have side effects, and we can classify it into local and systematic side effects. Local side effects such as swellings and fevers. And also we have the most dangerous side effects, but also it's very rare, which is anaphylactic shock, and it's need emergency. Not all pathogens have a vaccine. For example, still now malaria, it doesn't have specific vaccine for it. The benefits overweigh the risks, so vaccines are given to people. We must give it. And also scientists work to make and improve vaccines. We will give more details about the flu vaccine. Who should get vaccinated? As I said, mainly focus on the high-risk groups. Who are high-risk groups? Everyone, we can give it for everyone 6 months and old. We have mainly 2 types of the vaccines. We have injectable one and nasal spray one, and I will discuss or give more details about the main differences between them. About that اللي هو هون بحكي I'll talk about الshot flu vaccines. Who should get vaccinated? Everyone 6 months and older can receive it, especially individual at high risk of developing flu-related complications, and or if you live with or care for people with high risk for developing flu-related complication, or if you are medical staff, so especially in emergency rooms, so you are always in close contact or direct contact with patient, maybe they are flu patients. What's the absolute and relative contraindication for the vaccine? Who should not get vaccinated? People who have severe allergy to chicken eggs, and because the vaccine is prepared at chick embryo. Anyone who had known allergy to chicken pox, it's absolute contraindicated. So we must take a good history from the patient before give him vaccine. People who had a severe reaction to the vaccine in the past, people who developed Guillain-Barré syndrome after prior dose of the flu vaccines, and people with moderate or severe illness. People with moderate or severe illness, it's not, it's relative contraindication. We will wait until the patient gets well, and after that, give him the vaccine. About the nasal spray, injectable vaccine, it does about 0.5 ml. We can receive it IM, and as we said, it's given to the age from 6 months to the 65 years, and its type of it's inactivated or killed. But about nasal spray, we are in Jordan, we don't have just injectable type, we don't have nasal spray, nasal spray vaccine. Nasal spray vaccine, it's life attenuated vaccine, so any absolute contraindication to any life attenuated vaccine should not receive the vaccine. And about nasal spray vaccine, اللي هم بياخدوا healthy people aged from 2 years up to 49 are eligible for this type of the vaccine, and absolute contraindication for it, they should get the flu shot instead. Adults 50 years of age and older, or children from 6 through 23 months of the age, children younger than 5 years with any of this condition, asthma or one or more of episodes of wheezing within past years, the pregnant lady, because as I said, it's life attenuated. Injectable, it's safe for pregnant lady at any stage of the pregnancy. She can receive it from the first stage, from the first trimester of the pregnancy. People who have certain long-term health problems, muscle nerve disorders or weakened immune system. Also anyone in close contact with someone whose immune system is so weak, because it's, I said, life attenuated, and they require care in the protected environment. Also children or adolescents on long-term aspirin treatment. Does the shot cause the flu? It's the most common questions we received from the patient. The answer, no, the flu vaccine doesn't cause the flu. Maybe it causes flu-like symptoms, but it's not a flu. The viruses in the vaccine are weakened, as we said, it's attenuated or killed, inactivated, so the shot and the nasal spray won't cause you to get the flu. The vaccine will promote your body to develop the antibodies necessary to fight, and it's the mechanism of action, as we said, of the influenza viruses, and a slight reaction to the shot, such as soreness, redness, hotness at the site of the injection, and maybe we have mild muscle or fever may occur. Thank you for listening.
Thank you, Dr. Arich, for your nice lecture. All the questions, as I said before, at the end of the session. With the pleasure to introduce our last speaker today, Dr. Attar Ali Mahmoud. He is consultant of emergency medicine, clinical lecturer, University Melbourne, director advanced life support in Australian Association Council, emergency medical service trauma, advanced trauma life support instructor, stream lead clinical service of clinical governments, and also Australian of emergency medicine. He will talk about transformative scenario planning in healthcare.
Previous page, it's laser, but old push.
Okay. Good evening, everyone, and it's an absolute pleasure to be here today, and thank you very much. Merhaba, that's the only word I learned from the taxi driver, so apologies and forgive me for that. I'm not learning more of Turkish. Transformative scenario planning. Transformative scenario planning, so what exactly is this? It's actually a very complex social technology that kind of uses all the existing social models which actually kind of use for change management in our healthcare system, but using various combinations of it. It's about a transformative leadership. It's about transformative facilitation, where we actually bring people together to bring this change. It's a diagnostication tool. When we are actually stuck in a situation, it's actually it works. We'll go through that later. So, unfortunately, with the growing demands for the healthcare systems and our limited resources, we are faced with the change management all the time. So when we actually have this systems change, processes change, or whatever that's happening, we either actually faced with this choice. Either we actually accept it, adapt to the situation, or we challenge the situation to change it. Unfortunately, there's not much room to say, I don't want to change, because then perhaps we may not be part of the system anymore. I found this maxim very helpful at times to me. Niebuhr was an American theologist of the 19th century. And he said, Lord, grant me the serenity to accept the things that I cannot change, the courage to change the things I can, and the wisdom to know the difference. The last line, I always look back to it. I want to know which I cannot change and which I can change. So today's talk, what we're going to talk about is, we're just going to talk about a bit of historical perspective about where this transformative scenario planning process actually has come in. We'll give a bit of introduction about how change management happened that you must all have faced in your institution, in your hospital, in your health service, in your country. We'll talk about my story, that the Grampians Health, we took a major endeavor there, and how we use this technology, these systems in our health service. And we do a bit of more dwell a bit into the principles of transformative scenario planning. Thanks to Adam Cahan. Adam Cahan done a lot of work, and he's one of the pioneers actually establishing transformative scenario planning. Adam Cahan, he used to work first in the scenario planning division of Royal Dutch Shell Company. So Royal Dutch Shell Company was the 7th largest oil producing company at the time, and they had this division. This division of team would actually write different scenarios. So what would happen? What could happen? What may happen? And they would write these scenarios across globally, across regions, governments, political, geopolitical, wars. But their interest was, if something happens, what do we need to do? Their interest was money. And they also say that their interest had environmental impacts and all. Cahan worked in this division for about 2 decades. And he did not stumble across, he did stumble on the transformative process. It's purely by an accident. He was invited to Montfleur scenario planning meeting. This is the transitioning of South African post-apartheid government into the new government, into the newer systems. There was a lot of conflict, the conflict between the government, conflict between the rebels, the unionists, civil societies. Everybody had a different vision for how they want the change to happen, how they want the country to change. And there was a very famous joke at that time in South Africa. We are faced with only 2 options, a practical option and a miraculous option. A practical option is we all kneel down and pray to some angels come and take our problems away. And that was the practical option. Whereas the miraculous option was we all sit together and work and bring this change forward, and that was miraculous. So Cahan stumbled upon Montfleur. And then what he noticed, that has changed, that has actually developed into transformative scenario planning process. He worked after that in the Colombian transition, Guatemalan transition. He worked in Ethiopian the conflict management. So initially it went on to the high conflict zones, then it actually came to some civil society movements, health movements. There's a lot over the next 2 decades. He has worked a lot, and if any of you interested, these 2 books would be very, very useful. I refer still often to these books, and it gives me